been travelers from Nigeria in the UK about the 11th or 12th of May. And then suddenly they started to see an increase in cases, first in the UK and then in a number of other countries, and reported particularly from sexual health clinics. And most of the patients presenting with skin lesions with a slightly different distribution to what's previously been seen. So the situation is quickly evolving. Cases are being reported in several European countries, the States, Canada, and Australia. Not all of them are linked to travel to the UK. None of them are linked to travel to endemic areas. But there does seem to be a common thread with some gay pride events and similar. And they are mostly cases in males. I think there's one female, and there have been no deaths to date. So they're still putting the tree together, the source and linkage, but the strain seems to be a West African one, which has a much lower mortality, probably in the region of about 1%. So I think that's good news. We've had no suspected or confirmed cases of monkeypox in South Africa, and Jeremy's going to give us a differential diagnosis of vesicular lesions, because we certainly see lots of those. So monkeypox is endemic in Africa, but the cases to date have been seen in other countries, and this is a map that's been shared by the WHO, and I would suggest that you go to the WHO site. They have a daily update, and it's a very rapidly evolving situation. And here is what we have as of this weekend, and you can see where the predominant cases are based. Some are still being confirmed. I think everybody's grappling for their quickly for their pox primers to put in place something that can be used. So given that vesicular lesions are not uncommon in common diseases like chickenpox and then other, it's important that there's a case definition, and it's under development. Who should be tested? It's really an acute illness with fever, may or may not have headache. Lymphadenopathy is a very common feature of monkeypox, as opposed to some of the other clinical differential diagnosis, pain, myalgia, intense asthenia, and then a rash that develops first on the face where it's most dense, and then spreading to other parts of the body. And importantly, it occurs on the feet and palms of hands. So that's the suspected case. They've also given definition of a probable case, which is not laboratory confirmed, meets the clinical definition, but there's an epidemiological link to a confirmed or probable case. And then the confirmed cases are clinically compatible cases as laboratory confirmed. So what do we know about monkeypox? Well, it's one of the orthopox viruses. Smallpox is also an orthopox virus. And it's a viral zoonotic disease. It's found most commonly in the tropical rainforest areas in Central and West Africa. It has really nothing to do with an origin in monkeys. It got the name because there was monkeypox, so to speak, diagnosed in a group of laboratory monkeys that had obviously got it from somewhere else. There are two distinct genetic clades, the Central African one, which is more severe, more transmissible, and has a mortality rate of 10–11%. And then the West African one, which has a much lower mortality and is the current one that's being dealt with. I'm sure there's lots of sequencing going on of all the strains, and I'm sure we'll hear more of that now, but that's the one that's been predominant. So this is a lovely electron micrograph from Monica Burkhead, who's going to be quite busy supporting the diagnostic testing in our laboratory, and quite a large DNA virus. So how does it get transmitted? Well, I think nobody's completely sure. The reservoir is probably a rodent. Many animals can be affected and infected. And it's usually zoonotic transmission. In the most cases, the typical case is contact with infected animals through bites, scratches, bushmeat preparation, slaughtering, lots of that happening in the areas where it's endemic. A number of animals where it's been identified. In fact, the biggest outbreak was, one of the biggest outbreaks was in the United States in animals called prairie dogs that have been imported, but they're not dogs, they're actually rodents. Person-to-person transmission, the risk is low to moderate. Close contact, direct contact, prolonged face-to-face contact, kissing. It's not an STI in the traditional sense, but there obviously is close contact. And I think finding it in semen, for example, I think has not been confirmed, but I stand to be corrected there. Scabs, lesion fluid would be contaminated with virus. Droplet transmission has been put forward as a likely route of transmission. So, I think the transmission routes are variable and not absolutely confirmed in all cases. So the virus enters the body through broken skin, respiratory tract, or the mucous membranes, is the incubation, the prodrome, and then the classical lesions, which can vary in severity, but importantly need to be differentiated from other causes of similar lesions. So I think I've covered most of this. Happy to share the presentation afterwards. This is what it looks like. So it looks very much like smallpox. And I think what's very important is that the lesions are at the same stage of development and involve the palms and soles. Jeremy will mention some of the differential diagnoses, and I think the very important one here is chickenpox, where if you look at an area of skin, there are different stages of development. Smallpox, monkeypox, they're all at the same stage of development. Usually a self-limiting disease, can be severe, particularly in children, and in some cases leads to a pneumonia, and secondary infection is not uncommon, sepsis, and then a mortality in a small group of people. What about protection from severe disease? Well, the last smallpox vaccination in South Africa was in the 1970s. There is some cross-immunity. It's probably decreasing by now, but if you were vaccinated pre-1975, perhaps you've still got some immunity. But after that, obviously, that's a non-immune population. And that's one of the theories behind why we're seeing more smallpox in the endemic areas. And there's several thousand cases a year. It's failure, we're not using smallpox vaccines anymore, and it's waning immunity. And I think we've discussed all of that. So Jeremy, over to you. I think maybe let me just see if there's anything else, and then we'll come back to you at the end to look at the differential diagnosis. I'm a bit afraid I'm working with somebody else's computer and things. I might just lose you completely, and that would be a disaster. So just what to do if you have a suspected case. Establish that the patient meets the signs and symptoms for a suspected case. Must take infection prevention control measures. Isolation, universal precautions should be applied. And you need to minimize the exposure of health workers, other patients, and other close contacts. So the patient needs to be put into isolation with universal precautions. Clinical management is supportive, will vary from case to case, but typically cases are self-resolving. And I'll speak to the drugs and the use of vaccination in response to a case. If you have a suspected case, think about the differential diagnosis. And I think we can discuss that a little bit more. Give the NICD hotline a call. Notify your local and provincial communicable disease CDC so that they can start contact tracing and additional case finding. And then there will be a discussion, does your case fit the case definition? I guess we're going to get a lot of requests to test on patients who've got clearly other causes of vesicular disease. But if we do decide to test, samples can be tested at the NICD. We do have the primers and we are ready, but we will be screening the requests, otherwise we're going to be overwhelmed. I think we've been through the suspected case, probable case, confirmed case. You need to work on a suspected case based on the definitions there. So what specimens do we need? There is a case investigation form which you'll find on our website. That needs to be completed. You need to call the NICD hotline, which is available 24/7, and then we can do the testing on a variety of specimen types. I think probably the best one is lesion fluid or material from the lesions, vesicle pustule, scab, crust. You must be protected when you take these specimens, please. Note the swab type that needs to be used. If you've got viral transport media, that will be best, otherwise a dry swab. But this is the most important of the investigations. All the other specimens, throat swab, rectal swab, semen, plasma, and serum, are optional and can be discussed when we consider the specimen. There is a formal way to submit the specimen, very much like the VHF specimens, but we absolutely need to be informed that one is coming. A specimen is coming. They can't just kind of arrive in the post and get placed next to our lunch. Specimens should be sent cold during transport. So I think, please take note of this so we don't get overwhelmed with sort of non-specific throat swabs for smallpox. We've put everything on the website. There's the hotline number to note, and we've also added quite a lot of information on monkeypox. Just before I hand over to Jeremy and we can open for questions, there's been a lot of work done on vaccination for smallpox and for drugs for smallpox. And the reason for that is that it was considered a bioweapon by many. And so there's been a lot of investment in preventing and responding to bio incidents. So the smallpox vaccine, although smallpox, the material was destroyed throughout the world, there was a batch of smallpox vaccines retained. In fact, there is a strategic stock. I think it's held mostly by the US. They do vaccinate their military. They have several million doses. I think there's going to have to be a decision made about how this could be shared and who has access and how this access will work, given that it was really a US product and program. But if you vaccinate people soon after they present, or you vaccinate the contacts, you will reduce the risks of monkeypox and contacts, and also have some effect on the severity of monkeypox disease. I think the indications for vaccination, I think, haven't completely been worked out, and how one will access the monkeypox vaccine in the necessary time for it to be effective is something that needs to be reviewed. All of this is happening rather quickly. I guess it will be very similar to the Ebola vaccine. The strategic stock will need to be held either in the different regions or by the WHO, and then, I think shared with member states after some discussion about its value or use. And there have been a number of drugs, again, really around the use of smallpox in bioweapon warfare, which are effective or thought to be effective for monkeypox. Remember, the mortality is really quite low. Morbidity is variable. And again, the decision will have to be made who needs to be treated and how will the drugs be accessed. So we did find out about what we could access. There's a drug called cidofovir, or Vistide, Cidofovir. It's actually manufactured in India. It requires a Section 21, and we could access it in 14 days. I think there's going to be a great rush on these drugs, and there are a variety of them. And I guess, who gets what first is something we need to look at. But there are others. There's tecovirimat, there's Chimerex, some are oral, some are intravenous. I've never used these drugs, have no experience with them, have some of the package inserts, some are oral, some are IV, some have quite serious adverse events. This is something we're going to have to get our head around in the next few days about what to use when and how to access it. So not lots of experience here, in fact, no experience here of the drugs or vaccination using smallpox vaccine for monkeypox, but this is going to be a learning experience for all of us. I think the important thing now is to have good surveillance. I think cases are going to be seen. I think we need to look specifically around sexual health clinics, but also more broadly, make ourselves familiar with the differential diagnosis and then decide which cases will be tested. But we're open for business, but we need to, I think, just manage the process. So Jeremy, over to you, and then any questions people want to raise or experience they want to share. We're all learning in this. Thanks very much.
Great, thanks Lucille. So I've got the unenvious task of pretending I'm an expert in something I've never seen. So, so Lucille thought wisely so it would be a good idea to go through some of the differentials of vesicles specifically, in particular, the sort of things that might be confused with this. I don't envy the NICD's hotline people who will be sitting on the other end of that phone, because I think they're going to get many hundreds of phone calls in the next few days, because unfortunately vesicles are quite common in many infectious and non-infectious causes. Remind yourselves of a vesicle. It's less than a centimeter, technically in most textbooks, more than a centimeter is a bullous or bulla, and they're fluid filled, though. That's really the key thing of them. Now, Lucille mentioned as well that that these rashes can have multiple phases, which is pretty handy. It's almost universal that monkeypox has a rash, apparently. So in one really well written up case series of the 34 people who they had clinical signs and symptoms for, or clinical data for rather, all but one had the rash. So it really is a key feature of this infection. The other thing is, and Lucille did mention this, but it follows a prodrome usually. So you get this very non-specific and unhelpful fever, headache, chills, myalgia, back pain, the sort of things that would make you worry about COVID. And you're probably right. And if not that RSV, if not that flu. And the prodrome, though, is followed usually by the rash, so median of about 2 days later, but there's a range from more or less at the same time as the prodrome to up to 12 days later. But usually it's that kind of 1 to 3 day narrow band. And the key thing is that they evolve, apparently. So they start as macules and then become papules, then vesicles, which is the kind of at that point often that they present, because these do look unlike a lot of other vesicular rashes, where some of the macules don't always prompt healthcare seeking behavior. Then they develop into pustules, so they look like they've got pus in them, and then they afterwards go into either crust or umbilicate or desquamate. But this is quite a long process. From beginning to end of this is about 2 to 3 weeks until it gets there. So the first few phases may be a few days, but it does keep getting more and more, the duration at least is quite long compared to many other infections. That's a picture from eMedicine, and you can see that's the sort of pustular phase. There's the red base vesicles with the impression of an umbilication there in the middle on that one, but other ones developing into pustules. And you can see that these ones are a couple of millimeters long, or diameter rather. This is another picture. This is from that case series published in CID in 2005. This is actually this poor young girl here. You can see the neck is quite swollen. She actually developed a retropharyngeal abscess. But again, these similar kind of quite red-based vesicular lesions. These ones are a bit smaller than the previous patient's ones.
You see the pajamas on that one's also got a rash.
Yes, just determined. Clearly, yeah, should have chosen better with her pajamas. Just tempting fate. This is a picture from DermNet. This is of a person with black colored skin, obviously, which is really important because many of our patients, the rashes, always the pictures of the rashes in the textbooks always have American white skin, and it doesn't help to try and recognize here. And you can see the redness is quite hard to see on the base. in a different colored skin. But again, in this particular patient, you can get this impression of the umbilication quite prominently. So a vesicle here, but evolving to become umbilicated. This one on where the arrow is there, the vesicles actually come off now, and you can see the underlying skin sort of ulcerating. More lesions, again, also from DermNet. Again, you can see the sort of vesicular look to them, with some umbilication in some of them. And as Lucille said, typically all of the vesicles in the same stage of evolution, which is really, really handy, I think, because the differential is quite broad. So they're usually somewhere between 3 and 15 millimeters, the same stage of evolution mostly. Now, there are a couple of patients presented with crops, but most of them are on the same stage of evolution. Centrifugals, in other words, usually starts around the face and spreads peripherally more than centrally, although again, when the lesions are many, you're going to get lesions pretty much everywhere. They're not typically painful or itchy. That's, again, pretty handy considering some of the differentials to this rash. And then, as Lucille mentioned, the lymphadenopathy is quite prominent, and it distinguishes it very helpfully from chickenpox, and for what it's worth, smallpox. I mean, I don't know how much you need to know about smallpox, except that almost seems like tempting fate too. But apparently quite prominent lymphadenopathy, submandibularly, cervical, and inguinal regions, which is a key feature that may help. So this is smallpox rash, and you can see it looks quite similar. These are clearly old photos. We haven't had clinical cases in decades. Who knows, with the last remaining samples stored somewhere in Russia and America. And these lesions, again, this is the prototypical idea here of all of them being in the same phase. So it's virtually 100% of them occur in the same phase, whereas the monkeypox, sometimes you get different phases, although it's a pretty characteristic feature of it. Much more commonly, we're going to see chickenpox and herpes zoster. So with chickenpox, clearly the itch is a very key feature, as well as the fact that these lesions appear in crops. So they're not all in the same phase, which is actually pretty useful diagnostically. They have that kind of look of, what do they call it, a raindrop on a red rose kind of look to it, very a much nicer description than the rash deserves, perhaps. But you can see this kind of reddish base, and again, these vesicles on there, but they evolve as well to become pustules eventually, and then crust, but they're in multiple different phases of evolution as a very strong characteristic. They also tend to be on the smaller side compared to monkeypox. Again, usually starts on the face and spreads centripetally. But again, itch to me is a very useful thing, as well as the fact that they're in multiple stages. Now, zoster, the key thing there is the dermatomal distribution, which is really pretty hard to mistake for any other rash. That the whiteness there is some lotion that the patient had applied to one of the patients I saw. You can see there it's in the pustular phase, which doesn't, by the way, mean secondary infection at all. It's just neutrophils. You don't necessarily need any antibiotics for that. But again, the dermatomal distribution is the key thing. Obviously, it tends to be painful as well, very painful in many cases, much more than itch. But again, it's pretty hard to mistake a dermatomal rash for anything else. Hand, foot, and mouth disease is another common vesicular rash that we see in infectious diseases. Again, there the clue is the name, so hands, feet, and mouth. With, again, when we say hands, it can be the arm, and when we say foot, it can be the bottom part of the leg as well. Tends to be in those regions, but the key thing is the mouth lesions specifically are usually very painful. So you don't get oral lesions like this in monkeypox. And if you look in the mouth, you don't typically get oral ulcers there. Even the genital lesions, which are characteristic of this outbreak, at least in many patients, are not typical, apparently. And again, over here, it usually resolves in 3 to 4 days. There's a much more rapid evolution of these rash than you get with monkeypox. And then really briefly, because I've seen lashes on and can't forget fungi, this is a typical rash of Cryptococcus. So the things that are quite common here is that, again, it's quite umbilicated in many cases, not all, but many cases, and it can certainly be disseminated, although it doesn't have a huge predilection for face and hands and feet, or anywhere of the peripheries. It tends to be pretty much everywhere. The key thing here is that they're not vesicular, actually. They're papular, and so they don't have fluid in them usually. They're really nodules that have become umbilicated, or papules that become umbilicated. Also, obviously, the patient is profoundly immunosuppressed. So in the HIV sense, that would be a CD4 under 200. or equivalent immunosuppression in, say, a transplant patient or chemotherapy patient. And then very, very helpful, of course, the serum cryptococcal antigen is pretty much always positive in these cases. So it really does help rule it out pretty quickly. But again, the key thing there is that they are not vesicles. They don't go through a vesicular stage in a pustular phase. They're really nodules and papules, so they're solid. Although they can have a bit of breakdown in the middle, which gives them the umbilication. And again, if you're in doubt, a serum cryptococcal antigen will be very useful, given that this should be disseminated disease. And then for children, and really last, this bullous impetigo, it's not really an infectious rash, although it's caused by Staph aureus, but it's toxin mediated. And again, it's mostly the newborns that get this. And so really is quite specific to that age group in the vast majority of cases. And again, you're getting these these large vesicles, if you like, with red bases, but they don't go through the same evolution. And the child is otherwise pretty well, despite the rash on the face. So those are the common ones. If you look up the differentials in textbooks and review articles like I had to see what this has been mistaken for in the past, those are the ones I thought we'd cover. There is clearly a longer list of things that cause vesicles and bully, and we've only covered some of them, but these are the common ones, and these are the ones that are helpful to know about, I think, just to avoid phoning every vesicle through to the NICD, to the poor person who probably hasn't slept in the last week when you phone them. Just to make the comment, this is not the only pox virus, so this is for the ID specialists on the call. There are some other really interesting ones, and these are ones that have been seen in South Africa recently. So I don't know, Lucille, if you want to mention any of them now, if you want to hold them back for later, but there have been cases of ORF and Tonypox. Both these are sort of relatives. They are pox viruses, distant relatives of each other. But again, all of these other cases are usually just single or a handful of lesions, and they really spread by direct contact in the vast majority of cases. So you don't get this disseminated look where you have many tens, if not hundreds of lesions, which affect them. And these, I hesitate to put in your minds because they are really, really rare. But just to show you that there are other pox viruses, and for the ID people who've managed to sit through me droning on about it, there's something to take home. So again, the things that I think are useful, and I'm going to hand it back to Lucille and Trish at this point, but I think the same stage of evolution is a key characteristic here in the rash that would separate them out from most of the other differentials. Also, the fact that this is a characteristic evolution over 2 to 3 weeks. They're not just macules, they're not just vesicles or just pustules. They go through an evolution over days to weeks between them all. So there's a kind of a trend towards the rash, which, as you can see, some of the other differentials don't have. And then this lymphadenopathy, which is pretty common and is pretty useful because, again, things like chickenpox, which I think will probably be the most common non-monkeypox reason to phone the hotline for query monkeypox. There again, the lymphadenopathy is not there. And of course, in the case of chickenpox, the itch and the different stage of evolution is there too. So I think I'm going to leave it there. And I, like I said, always feel a bit uneasy talking about this. I've never seen a case of monkeypox, but that from the literature is some of the things that you can confuse it with and some of the helpful pointers which might help you not confuse it. I'm going to leave it there.
Thanks very much, Jeremy. That was really great. And I think it would be very important to add your presentation to what we include on our website, if that's okay with you. Can you just say something about molluscum? You know, we've had one request already, and I think it was probably molluscum plus or minus some cryptococcus, maybe in the background. That was the only one we've had to date.
All right. Okay. So that should perhaps have been on this then. So tend to be, so there's molluscum can occur in immunocompetent people, especially in children. Tends to be a few lesions. They tend to be quite small though, 1 millimeter, 2 millimeters. The central umbilication is common. And when it occurs as a sort of primary infection, you can have a bit of a fever with it. But again, it doesn't go through that trajectory of macules, papules, vesicles, pustules, and then evolution. It really is small little papules with central umbilication. And then, of course, it's got an HIV association in the persistence of it. So some of the HIV patients may also have molluscum as one of their AIDS-defining conditions. Which again, frequently on the face and extremities, but they tend to be very small, again, 1 to 2 millimeters on the whole, with very few exceptions, and that umbilication is pretty helpful. I don't know, again, there may well be other people on the call who know much more about it than me, so please do do shout. I'm going to stop my video and just allow everyone else to chip in if they would like.
Okay, thanks very much. It's really excellent. Just to answer some of the questions that have come through, and please add, I'm not expert on this. Dave Spencer asked about HIV and monkeypox. Obviously monkeypox is endemic in areas in Africa where HIV is endemic. I haven't yet managed to, I haven't looked hard enough. So I think that's something that we need to look out for. If anyone wants to add to that. And then Francois asked about us oldies and when was the last smallpox vaccine administered. According to Prof Schubert, I think it was 1974. So it was the mid-1970s. You can look on your arm.
And Lucille, do you know what age we were vaccinated at? I think that's also what France was interested in. So like in the US, it was at 1 year, and I think in the UK it was anything until a year. Oh,
yeah. So Nina was
9 months.
9 months, and so Prof Schubert said the last vaccination in South Africa was 1974. I think we just need to confirm it. The age, I don't know, but it was young. But I remember over a year. I was definitely over a year when I got that funny needle in my arm.
Alison is saying she was born in 76 and didn't get the vaccine, so that
no
74 cutoff. Just missed it, Alison. Sorry.
I think there was. Let's have a look at some of the other questions.
Narcisse is asking about scarring. So I did find that.
So they do scar. Yeah, they do scar. Okay, so where are the diagnostics done? At the moment, it's just NICD. It's something new. We do have the primers. We also have electron microscopy, and we need to, screen the cases and ensure that if there is a likely case, there is a public health response. There hasn't yet been any, decision or discussion around whether other labs will be able to or should be doing the diagnostics. To be honest, we haven't had time. It's really been extremely kind of rapid. So I think we're still finding our feet, but at least we've got the diagnostics. We have some experience of the primers. We have had 1 or 2 previous specimens, and we've certainly had a number of other pox viruses. We had all the ones you mentioned. Are there any other? So I think HIV is something we need to follow up on. And then I think there needs to be some decisions about treatment and access to treatment drugs. There's no strategic stock of any drug for some unusual disease in this country. So somebody has to import it, somebody has to do Section 21, and somebody has to pay. So that's a discussion, and maybe that will be discussed this afternoon at the meeting with the DG. Anything else, Jeremy, that you can?
Nilesh is asking about what precautions to take. I've got it on there. So that's from the CDC. So they recommend standard precautions, droplet and contact. So not airborne, but droplet and contact, basically, in addition. So the droplet part being, we're all very now familiar with this with COVID, except that COVID's got the addition of aerosols as well. But you can see there the droplet precautions versus the contact precautions, but not in theory requiring N95s, for example, or other aerosol measures. I feel like we've heard that before, though, but I think it's slightly more established. It's a relief to have an outbreak of a virus which is not brand new. I tell you that's made at least we're starting with a knowledge base here, albeit.
And then this question about the distribution of the rash in the groin area. I think that was one of the initial presentations that drew, people's attention to this being in a specific group. I haven't seen any pictures of the rash in the actual patients. I don't know if anyone has. Not sure if they've been released, but we can certainly look for those. Any other questions that we need to respond to?
I mean, I think that I feel very cautious about making any optimistic predictions given how badly burnt I got on COVID. But I mean, the fact that this is not usually thought to be transmissible and other than through fairly close contact, through droplets or contact. And the fact that this does seem to be a cluster of MSM, for example, the majority, at least the overwhelming majority, hopefully suggests that this is going to be not too long-lived, this outbreak. I guess, is it way too soon to even be optimistic about that? Or what do you think, Lucille?
I think it's too soon. It's like
I'm sticking my neck out
worth.
just to be crushed again, just like I was.
But Dave's asking about condoms, prevention, about community awareness and communication. I think that is obviously important, and that's something we need to include in our responses. We're going to learn more, and I think the next few days are going to be a learning experience for all of us. Will we see a case? Not looking in the looking glass, can't tell you.
And just to answer the last question, there haven't been any cases detected?
No, nothing. And we haven't tested any either. I think we need to be quite selective in testing. It will stigmatize patients who may definitely not have anything related. So, I think we need to apply those case definitions. I think pictures of rashes are really important, and we can call on our infectious disease specialist community to help NICD and the hotline screen the cases. I think that really will be very important. Travel history, I think initially yes, but in like Canada, Spain, Portugal, there is local transmission. So I think a travel history is on the CIF form, but that may move into a different phase. I think all important points to raise. And then information about communicating with the community, the currently at-risk community, I think has already been started. So that's really good. Johan, you want to add anything? Johan Hugo? Do you want to chip in here about the communication?
Johan, let me find you, because you're going to be able to, there we are.
You're going to be muted.
You can unmute if you'd like.
Hi guys, no, I just wanted to say I work for Health for Men for Renova in Cape Town, and I was just going to say that we have been looking at the situation for the last week or so, obviously because I work for an MSM. Our clinics are mainly focused on MSM, and we definitely want to put communication out there for our clients, because I've seen a lot of stuff already floating around on social media, and we just don't want any disinformation out there. Yeah.
And I think Nilesh has raised a really important point. Condoms alone are not enough, because skin contact would be probably, I think, a very important area for transmission. The CIF is going up. I think all of that will happen soon, or is happening at the moment. So just give everybody an opportunity to kind of take a deep breath, and I'm sure it will be out there. Any other points to add? Anybody wants to chip in? I see there's any hands up? No. I think it's a learning experience, and we value all additions and anything that people can add.
I've put a link to the NICD page in the chat, and it's got the CIS there for people who can't otherwise find it. And then there's also CPD points available. I've put the link for that too. Ripka, you've got your hand up. Do you want to go ahead?
Lucille, Jeremy, in the initial outbreak, why was monkeypox suspected, and how did they come to the initial diagnosis? Vesicles being relatively common, what triggered the initial suspicion of monkeypox?
So the monkeypox was confirmed in some travelers returning to the UK from Nigeria, 1 and then 2. And they've had experience previously of confirming cases, sharing the information. And then the other cases occurred quite quickly after that, cluster with, sort of almost classical lesions, but in a slightly different distribution. And I think with the diagnostics available and monkeypox being quite high on the agenda over the last 2-3 weeks because of the imported cases, I think that followed, the diagnosis followed, but it was an unusual presentation. And good for them that they made the diagnosis. So I think we've answered all the questions. Something about anti-vaxxers are. Alison, I'll leave them to read it.
I agree with Alison. Trish, anything from your side?
No, nothing so far.
Okay, cool.
You're going to be the busy one, Trish and co.
Yes, I think we might need additional support at this rate.
So you will. I think there are a lot of ID people who are very willing to support the history of exposure, the clinical picture, and a picture of the rash, and a little bit, more background information shared with some ID physicians and others. I think would be of great benefit, and we'd really like that. Thank you.
That's actually a really good point, Trish and others at the NICT. If you'd like, we could do something through the Infectious Disease Society of South Africa.
Yeah, I think that would,
like a WhatsApp group for support or something, just to help.
Yes, please, that would be fantastic.
I say nervously, but at least the load will be spread.
Yeah, thank you so much. That would be great, appreciated. I did just want to also add that we have been working on a few sort of quick look support documents that will be up on our site under monkeypox for clinicians in the field. It includes the case investigation form, as well as just a differential list and what to do, just as a reminder, so you don't have to look up the presentation if you do have a suspected case, how to manage it and who to contact for help.
Great, that's really, really handy. Congrats to the NICT for moving so quickly on this. This is it's incredible. I mean, it's a huge feat. I mean, already there's an entire web with multiple documents, a case investigation form.
Yeah, and I think the staff have done a fantastic job. Thank you.
Yeah, no, congratulations.
Is that an old hand, Ripka? I'm not sure. Not sure. Jeremy, do you want to mention the Lassa in the last 15 minutes?
Sure, you'll have to take it, but I think it's a nice case.
I'll do it. I'm not sure I'm going to find my presentation.
Okay.
I'm very bad at this. Wait, hang on.
Lucille, by the way, while you look, I'll just tell the audience, Lucille's been a superstar. She's managed to pull this all together from yesterday afternoon's phone call. We had a change in
last
schedule.
Night, actually, yeah.
But yes,
last night.
So she's a champion and stalwart of this all. Thank you to her and Jackie and Trish and all the others from the NICT for being
really great.
So helpful at very short notice.
It's going to be a learning exercise. Things are going to change, and we're going to add to our knowledge. Don't know it all. I'm not sure if you can see the presentation. Did this all on my own?
Not yet, no.
Oh, hang on. I don't think I shared the screen. Oh, Lord. See, I told you. Sitting in the bush at a workshop. Hang on a sec. Share screen. There you go.
And Dave's asking while we say about the early vaccination. So you're absolutely right. So I mean, that is the experience, at least in the literature, that vaccination does attenuate the vesicle size and prevent a lot of the scarring. But as Lucille was saying, that it doesn't seem to be a clear way of accessing the vaccine. At least if there is a scramble for it, the amount available will probably be quite limited to that ever gets to South Africa. So at the moment, no way to get the vaccine, right, Lucille?
No, I think that will also be discussed.
Okay.
How to access it quickly.
Okay.
Yeah.
Great. Okay.
For the most part, they get better, but we don't know about our immune suppressed population. Can you see it now?
Yes. Yeah. Looks good.
Oh, wonderful. Okay, so I'm just presenting two cases just to remind people about the disease, and always to kind of question the diagnosis and think about the history. So the patient also in the last 2 weeks, it's been quite busy, 60-year-old South African. He lives and works on a sugarcane plantation in rural Nigeria in Nasarawa state. I'll show you a map shortly. He presented with fever and gastro. He tested for malaria, it was negative. He went to the local practitioner, didn't get better. This was over a period of about 8 days. He decided to fly home, commercial. He was a little unwell. And almost immediately, he was admitted to the private hospital near his home in KwaZulu province. He did a number of blood tests. The white cell count was raised. The platelets was initially 65,000, increased over a couple of days to 110,000. That's not 11,000. There was no bleeding. He was given some antibiotics. The stool on a biofire tested positive for Shigella and E. coli, and the blood culture tested positive for E. coli. That should be a small c, sorry. Over a period of a few days, he deteriorated again, initial improvement, then deteriorated, was admitted to the intensive care unit, intubated, ventilated, and dialyzed for a period of just over 24 hours, and he died. And there was some consideration for other diagnoses, although the working diagnosis was E. coli septicemia. So they sent blood to us for dengue, yellow fever, and for Rift Valley fever. And our practice in the lab, and I think it's a really important one, if you get any requests for any of these diseases or viral hemorrhagic fevers or arboviruses or rabies, you go back to the doctor and you get a history. Who is that patient? Where have they been? What is the likely diagnosis? Is there something else we need to be looking for that wasn't asked? And can you justify the request for these tests? He'd had a yellow fever vaccination. He traveled from South Africa to Nigeria and back very frequently. It is a requirement, but you know, some people slip through and it's not 100% in everybody. It's not a Rift Valley fever area and there haven't been any outbreaks. And this is an unusual presentation for dengue. So I had a look at this and I thought, oh goodness. Nigeria is endemic for Lassa. There's Nasarawa state in the middle. It's quite near some states that had reported cases this year. But he likely travels around the area, and there are cases that go undiagnosed of Lassa. In some people, it's subclinical. And I think what really alarmed me was the fatal outcome and the fulminant hepatitis. It was hepatitis A negative, hepatitis B negative. Don't think they looked at herpes, but a patient from Nigeria with a fulminant hepatitis, irrespective of the platelet count and lack of bleeding, you have to consider Lassa. We've seen in previous cases secondary bacterial sepsis, and I think in a patient with fulminant liver failure, it's not unusual to get a secondary bacterial infection. So fortunately, we had the blood. The patient had already died, but his body was in the mortuary, and we tested, and Lassa fever was positive on PCR. And I think it's really important to confirm the diagnosis. Well, there's not much we could do for the patient, and I'm not sure there was a huge amount we could have done with him, for him at that stage of his illness with the fulminant course. But there's an absolute need to monitor staff, any staff who'd looked after him, any of the people who'd been kind of within a meter. Remember, he'd had a lot of invasive procedures, dialysis, ventilation, and there were many risks. So as soon as we had the diagnosis, we brought in the communicable disease control people to follow up the family. The infection prevention control and the hospital identified close contacts, those who looked after him, those who were in contact with any bloods or secretions. We notified the lab who'd done the specimens, the blood bank, the ED, anybody who might have been at risk, and instituted monitoring using twice daily temperature monitoring and active reporting. Everybody has to report, otherwise you have to go and hunt them down. And it's very important that people don't leave the area. You don't want somebody who's a Lassa fever contact going off to the Khalkhadi or the United States within the incubation period. And it's a period of 21 days that you need to monitor. Now, one of the signs symptoms that's quite common in Lassa fever is sore throat, edema of the face, ulcers in the mouth, and that's something you need to look out for. We are in the middle of respiratory disease outbreaks. We have RSV, we have influenza, H1N1, we have COVID. So, you know, everybody's got some sort of respiratory illness, and anybody who's been in contact is going to have, you know, some symptoms, real or not real. There were no high-risk contacts, so no needle stick injuries, no splashes in the eye, but there were in total about 60 people who had had some sort of contact with the patient in the hospital. So we had four staff, 2 of our own, and 2 in the hospital, one who'd helped with dialysis, one who'd helped with intubation, who developed fever, upper respiratory type symptoms. We did formal bloods on them. We did primary bloods, liver functions, FBCs, and we also tested for Lassa. They were all negative. The one had a influenza A, H1N1, and the rest were all negative. I think one has to be careful in this sort of response not to go for the respiratory panels first, because you know, there's so much respiratory illness around. You could have positive COVID, but still have Lassa. And just a little while ago, we had a farmer from the Karoo who presented with upper respiratory symptoms, headache, fever, but a low platelet count, really low platelet count, of something like 12,000. And in fact, he had COVID. And because of the low platelet count, being a farmer in the Karoo, we also tested for Congo, and he was positive. So he was Congo and COVID. So just be careful about other things that are coincidentally circulating. We're now at 14 days. There have been no further contacts identified. Incubation period can be up to 21, but it's generally less than 12. So hopefully we're out of the woods. Contacted the International Network for VHF, and they're a fantastic group. We were looking for drugs for treatment. We have oral ribavirin, which may have some benefits. It's not ideal, especially for perhaps close contacts, needle sticks, splashes, but there weren't any of those. But we thought we would look for other drugs in case there were other cases. There's almost no intravenous ribavirin around. We imported some years ago for our Lujo case. I think it was R500,000, but she got better. But the sources of kind of are not evident. There is a new drug called favipiravir, and that was offered to us for compassionate use, in fact, through a trial that's being done. So the VHF clinical network is fantastic. They all came and gave support and advice, and even drugs were offered to us. So I think we're probably over the worst, but we'll have to wait and see the 21 days. I think the most important is to think of where the patient has been, what is common there, especially if there's a progressive hepatitis. Bleeding is not always evident in Lassa fever, and low platelets may or may not be present. But think of it, and we're always happy to discuss and to test. And some years ago, this is the only other case of Lassa fever that came our way. It was also missed. He was a Nigerian public health physician, presented with fever, abdominal pain, low platelets, low white cells, abnormal liver functions. He seemed to have an initial response to a quinolone, which I think he gave himself. So typhoid became the presumptive diagnosis. And one must be very careful of some of the diagnostic tests. There are some rapid serological tests for typhoid that kind of hang around many areas. But you know, serology is not always helpful, especially if there's background typhoid. Anyway, he got worse. He had convulsions, renal failure. He did start to bleed. And at the time of transfer to South Africa, in fact, he had a normal white cell count and platelets. He was flown from, I can't remember if it was Abuja or Lagos. It was an 8-hour flight. It was quite a difficult flight. He was intubated. There was some bleeding, and he was brought to South Africa as a typhoid. Fortunately, there was a very, very astute paramedic who went to Lanseria to fetch him. He'd been involved in the local Ebola case in the 1990s, where the nurse contracted Ebola from the doctor from Gabon. So he knew Ebola, he knew viral hemorrhagic fevers. When he saw the patient, he said, Nigeria, physician, bleeding, this must be Ebola, and he raised the flag. So immediately on arrival, the right viral hemorrhagic fever precautions were applied. He was transferred to an ICU in Pretoria. He was ventilated, he was dialyzed, and we confirmed the diagnosis of Lassa really very quickly. And it's thanks to that paramedic who raised the alarm. I hate to think what would have happened if it hadn't been raised and he was continued to be managed as a typhoid. I think we might have seen more cases. So I think it's astute doctors. I think it's about diagnosing what you know, and really about good histories and putting the pieces together. And I'll leave you with a couple of messages. So that's the end of my presentation, and we're spot on 4 o'clock, Jeremy. Thanks very much.
You're an absolute pro, Lucille. Down to the second. A couple of questions on the Lassa in the chat. Ruan's asking, do you know if either of the cases developed sensory neural hearing loss as a complication?
Well, they didn't survive.
Very good point. But before,
yeah, so they both died. So
okay.
neural loss is an issue. There are a number of patients who have very mild or subclinical disease, and that is a common feature. But unfortunately, yeah, they both succumb.
And then Lauren's asking about safe burials for these patients.
Yeah, so that's a really important point. The body of this most recent patient was in the mortuary. You absolutely don't want a post-mortem. There are other ways of making the diagnosis that are much safer. Safe burial is really important. There are instructions in our VHF manual. It's usually 3 layers of body bags with some hypochlorite in between, not viewing the body, not touching the body. But that, in fact, the latest patient had been in the mortuary for quite some days before anybody kind of, thought to raise some other diagnoses. So absolutely critically important, and nobody should do a post-mortem on things they don't know or have some idea about.
Yeah, thank you very much. So you've had a busy few weeks, you guys at yourself in ICDT.
Yeah, I think it's a team effort, and the team have really performed incredibly well.
Yeah, absolutely. Yeah, incredible. Thank you very much, Lucille and Trish and all the others, Jackie, for contributing to the meeting, even though she couldn't be here. But really, really, really important and good and topical, and I hope that helped at least some people. We're all having to read up a lot and furiously about this thing, but at least we have somewhere to start. Like I said, at least this isn't an outbreak of a totally unknown thing like COVID was. We've at least got a bit of a head start knowledge-wise, even if there's still gaps.